Officer, then Dr. Howard New, Deputy Chief Public Health Officer, and we will also have Dr. Matthew Tunis, Executive Director for the NACI Secretariat, who will be answering questions. So this is all going on virtually, and we'll start with Dr. Tam.
Merci, and bonjour à toutes et à tous. Nationally, the daily case counts continue to increase, but there is still considerable regional variation in disease activity. Over the most recent 7-day period, an average of over 2,800 new cases were reported daily across Canada. Currently, severe illness trends have leveled off, but are still elevated and could begin to rise again unless we keep infection rates down. Over the past week, on average, 1,540 people with COVID-19 were being treated in our hospitals each day, including 465 in intensive care, and 19 deaths were reported daily. The emergence and spread of the Omicron variant of concern, including 11 recent detections in travelers coming into Canada and or their close contacts, is yet another reminder of how quickly things can shift in this pandemic unless we continue to reduce the spread and impact of the virus with vaccination and other layers of protection. In addition to strengthening diagnostics, therapeutics, infection prevention control, vaccine uptake, and other response aspects, experts on Canada's National Advisory Committee on Immunization, on NACI, have continued to update guidance to help strengthen our COVID-19 vaccination programs. Today, NACI updated advice on COVID-19 mRNA vaccine booster doses, as well as recommendations on the use of mRNA COVID-19 vaccines in adolescents and young adults. NACI recommends, and health authorities in Canada agree, that immunization in those who are eligible but have yet to receive their primary series should continue to remain the top priority in Canada and around the world. NACI has reaffirmed that the benefits of receiving an mRNA COVID-19 vaccine continues to outweigh any potential risk of experiencing rare side effects following immunization with an mRNA vaccine, including the rare risk of vaccine-associated myocarditis and/or pericarditis, most often seen in males aged 12 to 29 years. Regarding boosters, NACI considered emerging evidence on waning protection of vaccines over time and the safety and potential benefits of mRNA vaccine booster doses. In the context of the Delta variant, evidence suggests that vaccine effectiveness against infection and symptomatic disease decreases with time, and possibly against severe illness as well, especially in older individuals. No additional safety concerns were noted following mRNA vaccine booster doses. The rare risk of myocarditis and/or pericarditis appears to be lower after the booster dose than after the second dose of the primary series, though is higher than after the first dose. Based on this, NACI has increased the strength of their recommendations to now say a booster dose of an authorized mRNA COVID-19 vaccine should be offered 6 months or more after completion of a primary COVID-19 vaccine series to people aged 50 years or older. Adults living in seniors' long-term care or other congregate living settings that provide care for seniors. People who received an exclusively viral vector COVID-19 vaccine series consisting of only AstraZeneca Covishield and or the Janssen COVID-19 vaccine. Adults in and from First Nations, Inuit, and Métis communities, as well as frontline healthcare workers having direct, close physical contact with patients. NACI further recommends that a booster dose of an authorized mRNA vaccine may be offered 6 months or more after completion of a primary COVID-19 vaccine series to adults aged 18 to 49 years, with consideration of jurisdictional and individual risks. Finally, with respect to vaccination of adolescents and young adults, NACI considered new Canadian and international data that suggests the rare of myocarditis after receiving an mRNA COVID-19 vaccine may be lower with Pfizer-BioNTech Comirnaty 30 microgram vaccine as compared to the Moderna Spikevax 100 microgram vaccine. These data also show that a longer interval between the first and second dose in the primary vaccination series results in a stronger immune response and higher vaccine effectiveness, and that longer intervals may also be associated with a lower risk of myocarditis and/or pericarditis. Accordingly, for adolescents and young adults aged 12 to 29 years, NACI now recommends that the use of Pfizer-BioNTech Comirnaty vaccine is preferred over the use of Moderna Spikevax vaccine to start or complete a primary vaccine series. NACI further recommends that the second dose of a primary mRNA COVID-19 vaccine series should be provided 8 weeks after the first dose. Now and during the winter months, while the virus continues to circulate worldwide and the significance and impact of the Omicron variant of concern is being assessed, the need for heightened vigilance remains. Regardless of which variant is circulating, we are better protected individually and collectively when we all do our best to maintain layers of protection by completing the COVID-19 primary vaccine series and getting a booster shot dose as recommended, wearing a quality, snug-fitting mask, avoid crowding, and taking other measures as possible. Thank you. Merci. Miigwech.
Bonjour à toutes et à tous.
Good morning to everyone. Nationally, daily case counts continue to increase, but there's still considerable regional variation in disease activity. Over the most recent 7-day period, an average of over 2,800 new cases were reported daily across Canada. Currently, severe illness trends have leveled off but are still elevated and could begin to rise again unless we can keep infection rates down. Over the past week, on average, 1,540 people with COVID-19 were being treated in our hospitals each day, including 465 in intensive care, and 19 deaths were reported daily. The emergence and spread of the Omicron variant of concern, including 11 recent detections in travelers coming into Canada and/or their close contacts, is yet another reminder of how quickly things can shift in this pandemic unless we continue to reduce the spread and impact of the virus with vaccination and other layers of protection. In addition to strengthening diagnostics, therapeutics, infection prevention and control, vaccine uptake, and other response aspects, experts on Canada's National Advisory Committee on Immunization, or NACI, have continued to update guidance to help strengthen our COVID-19 vaccination programs. Earlier today, NACI updated advice on COVID-19 mRNA vaccine booster doses, as well as recommendations on the use of mRNA COVID-19 vaccines in adolescents and young adults. NACI recommends, and health authorities in Canada agree, that immunization in those who are eligible but have yet to receive their primary series should continue to remain the top priority in Canada and around the world. NACI has reaffirmed that the benefits of receiving an mRNA COVID-19 vaccine continue to outweigh any potential risks of experiencing rare side effects following vaccination with an mRNA vaccine, including the rare risk of vaccine-associated myocarditis and/or pericarditis, most often seen in males aged 12 to 29 years. Regarding boosters, the National Advisory Committee on Immunization considered emerging evidence on waning protection of vaccines over time and the safety and potential benefits of mRNA vaccines vaccine booster doses. In the context of the Delta variant, evidence suggests that vaccine effectiveness against infection and symptomatic disease decreases with time, and possibly against severe illness as well, especially in older individuals. No additional safety concerns were noted following mRNA vaccine booster doses. The rare risk of myocarditis and or pericarditis appears to be lower after the booster dose than after the second dose of the primary series, though is higher than after the first dose. Based on this, the National Advisory Committee on Immunization has increased the strength of their recommendations to now say a booster dose of an authorized mRNA COVID-19 vaccine should be offered 6 months or more after completion of a primary COVID-19 vaccine series 2, people aged 50 years or older, adults living in seniors' long-term care or other congregate living settings that provide care for seniors, people who received an exclusively viral vector COVID-19 vaccine series consisting of only AstraZeneca, Covishield, and/or the Janssen COVID-19 vaccine, adults in or from First Nations, Inuit, and Métis communities, and frontline healthcare workers having direct, close physical contact with patients. The National Advisory Committee on Immunization further recommends that a booster dose of an authorized mRNA COVID-19 vaccine may be offered 6 months or more after completion of a primary COVID-19 series to adults aged 18 to 49 with consideration of jurisdictional and individual risks. Finally, with respect to vaccination of adolescents and young adults, the National Advisory Committee on Immunization considered new Canadian and international data that suggests the rare risk of myocarditis after receiving an mRNA COVID-19 vaccine may be lower with the Pfizer-BioNTech's Comirnaty 30 microgram vaccine as compared to the Moderna Spikevax 100 microgram vaccine. These data also show that a longer interval between the first and second dose in the primary vaccination series results in stronger immune response and higher vaccine effectiveness, and that longer intervals may also be associated with a lower risk of myocarditis and or pericarditis. Accordingly, for adolescents and young adults aged 12 to 29 years, NACI now recommends that the use of Pfizer-BioNTech Comirnaty vaccine is preferred over the use of the Moderna Spikevax vaccine to start a complete primary vaccine series. NACI further recommends that the second dose of a primary mRNA COVID-19 vaccine series should be provided 8 weeks after the first dose. Now and during the winter months, while the virus continues to circulate worldwide and the significance and impact of the Omicron variant of concern is being assessed, the need for heightened vigilance remains. Regardless of which variant is circulating, we are better protected individually and collectively when we all do our best to maintain layers of protection by completing the COVID-19 primary vaccine series and getting a booster dose as recommended, wearing a quality, snug-fitting mask, avoiding crowds, and taking other measures as possible. Thank you.
Merci beaucoup.
Thank you very much. We will now move to questions on the phone. Operator, over to you.
Thank you. Merci. You may press star 1 if you have a question. Vous pouvez appuyer sur étoile 1 si vous avez une question. La première question de Raymond Fillon, TVA.
Raymond Fillon, TVA, over to you. Good morning. Dr. New, at one point, is Omicron a reason to get a booster shot? Is this why you're asking all adults to get the booster shot? Not at all. The Omicron variant is still being studied. We are trying to understand its implications because there are three big questions which apply to any variant of concern. One, is it more transmissible? Two, does it lead to more serious illness? And what are implications regarding vaccines? We don't have the answers to those questions, and scientists around the world are continuing the work to answer those questions. But for now, what we're seeing in Canada is that the Delta variant is the dominant virus which is circulating in this country. We also see that the vaccination effort in Canada is going well. Canada has done well. Vaccine coverage is quite high, but we can do better. So it's important to continue with the vaccination. What we're now seeing with the evidence, we're getting the first indications that vaccine protection may be waning, perhaps more in seniors and those who have received the primary series of the vaccine at the beginning of 2020, as opposed to other age groups which got their vaccines a bit later. So it's important because with winter looming, people will start to gather indoors. So it's important to point out that we should also still be taking the other protection measures. That said, the study and analysis of the data on boosters has started, is ongoing, and that work was even happening before Omicron appeared on the scene. Regardless of what variants emerge, we continue with our work, with our study. And that work will continue despite the advice on booster shots now. Thank you. However, some people are saying that a longer time span between the booster shot and the second shot shouldn't happen after 6 months, but later. What do you think of that? Thank you for the question. It's a good question, and we're seeing this in other countries, so it's really important to see what is happening elsewhere. So in countries like Israel and in the United States, which applied a shorter interval between the first and second doses, depending on the manufacturer of the vaccine and the population groups. We've seen that the effectiveness has gone down when the first and two shots were closer together. And the advantage here in Canada is that we were able to learn from other countries' experiences, so we decided to increase the time span between the first and second doses, so Canadians are well protected against serious illness. But the first indications are emerging that protection is beginning to wane. So we believe this is the right time to have booster shots. Again, looking at the data, we've seen that the booster shots can improve immunity and increase the longevity of the effectiveness of the vaccine, which is why we're recommending booster shots. We don't want to wait too long, because we don't want to wait for hospitalizations to increase and deaths to increase. It's already time is already pressing, because by the time you roll out a vaccine campaign, a couple of weeks can go by. So we want to give everyone protection, and we believe the time is right now, before the Christmas holidays, before people start going indoors, to launch a vaccination campaign for booster shots for priority groups. Thank you.
Opérateur, prochaine question.
Next question, operator.
Thank you, merci. The next question is from Mackenzie Gray from CTV News. Please go ahead.
Hi, doctors. I'm just looking to get some clarity on why the recommendation is for people 50 and up, they should get a vaccine, but for people 50 under, it's discretionary for a NACI recommendation. I think it's pretty clear from the language in the report, and Dr. New, from what you said earlier, that it seems like it's only a matter of time for adults who are below 50 that they're going to get a vaccine. Why not get ahead of it now and recommend and open up eligibility to everyone at this point in time?
Yeah, thank you for that question, and I'll take it first. So I think our primary focus and that of the NACI recommendation is still to strongly recommend it for the groups, not only because they were at higher risk potentially for serious outcomes, but that they were immunized earlier. So the recommendation is that the booster dose should be offered 6 months or more after completion of a primary series. So both the duration of when someone has received that vaccine, as well as whether they're at a higher risk of serious outcomes, are taken into account. So NACI also strengthens their recommendation over time as well as more data becomes available. As Dr. New had said in French, the data that we have at the moment shows that the vaccines are holding up pretty good against severe outcomes. We're most concerned about severe outcomes in those who are elderly or have other higher risk conditions that we talked about. There is certainly a direction of travel in terms of the waning of the vaccine effectiveness over time against asymptomatic infection and any symptoms. So that's why I think the recommendation is stratified. And for the younger people, they probably haven't reached that 6-month mark as yet.
I'd like to ask about comments of the Moderna. Sorry, go ahead.
Sorry, just one more point to add in addition to Dr. Tam's comments. Something else that was discussed by the committee was the fact that in those 50 and older, they do have increased rates of underlying medical conditions as well, which is part of what's grouped them together. Thanks.
The Moderna CEO has said that vaccines may be less effective against the new Omicron variant. What would you say to Canadians who would say, you know what, I'm going to wait on getting the original formula of the booster now and wait for a potentially new formula that could come out within a few months?
Yeah, thank you for that question. So at this current moment, Delta variant is the most dominant variant. It's like 99.8% of what we have in Canada. And so we have to mitigate the risk of this present threat. So I think the primary focus, I think as Dr. New has said, is that the NACI recommendations were going to come out anyways this week, Omicron or not, to recommend the booster dose, as we've just described, to persons over the age of 18 to adults. And so I think the extent of the protection against Omicron from the primary series and booster dose remains to be seen. And we're going to learn a lot about this in the days to come. But nevertheless, it is still prudent to maximize the possibility of protection from vaccine by, first of all, offering the vaccine to anyone who hasn't had the primary series, but then offering the boosters as we've just laid out. And the Omicron variant specific vaccines are going to take months, but right now we have the potential for a Delta surge.
Opérateur, prochaine question.
Operator, next question. Catherine Lévesque, the Canadian Press. Over to you. Good morning, doctors. I'd like to come back to the question asked by my colleague Mackenzie. Last week, the federal health minister seemed to say that he would ask NACI about booster doses because of Omicron, but it seems that there was no connection.
Oui, donc, c'est pas la première ligne directrice de cette comité. C'est prochain chapitre.
This is simply the next chapter. The committee has had already organized discussions on boosters that week. So I assured the minister when he asked, when will the advisory committee come out with its next recommendations? I said, well, it's happening this week. So it was very timely.
When the minister asked me the question, can NACI take another look at the booster dose recommendations? I said, well, NACI is actually meeting this week already to look at the next stage of the booster recommendations. So here we are. I thank the committee and everyone who worked on it in an expedient manner. But I think everyone's been looking forward to this recommendation.
Yep, it's Dr. New. I can maybe just add to what Dr. Tam has said. It's right. The committee has been looking at this issue for quite some time, and it takes a while to analyze the data, looking at things such as the dose interval, what is the experience in Canada, the good level of protection we've had in the general population, and how it might be slowly diminishing, but maybe, as I said in French, maybe not at the same rate as in other countries that had that shorter dose interval. So that's all been taken into account. And now, as we said, I think it's a good time to make the recommendation, which NACI is doing today with the booster doses, as we are now gathering insight with the winter. Lots of other things are happening, such that with the fact that we don't want to wait too long, because if we wait to get the actual data on, increasing hospitalizations and other lagging indicators, then it'll be too late, because, even with a vaccination program, it takes 2 weeks, for an individual who receives a vaccine to actually get, maximum protection. And so all those factors have led to this moment, and it's not, just because of the Omicron. It's sort of, good timing as well, because it just highlights the importance of vaccination, but it's not because of the Omicron variant per se. Thanks.
Thank you very much for that. I'd like to come back on the 6-month interval. I'd like to know what NACI used to determine that interval. Are there any studies out there or data from other countries which we use to come to that figure of 6 months? Thank you. Dr. New here. I can start answering, and Dr. Tam and Dr. Tunis might complete my answer. Clearly, our experience here in Canada, well, I think we are leaders because we've shown other countries how our vaccine programs and policies and the intervals we applied between the first and second doses, we showed that this gave Canadians stronger protection for a longer time. And it was through the analysis of the data that NACI came up with recommendations to say it's good to wait 6 months at least before getting a booster shot. So 6 months after the first series of vaccines. Even with the principles of vaccinology and immunology, which are well established, it's clear that if the vaccine administration interval is longer, the vaccine is more effective. Perhaps Dr. Tam and Dr. Tunis would like to complete the answer.
Yeah, I can add some additional context also. So one thing to keep in mind is that the authorized intervals by the regulator are also 6 months after the second dose. So the majority of the evidence that has been generated around booster doses is looking at a 6-month interval. That was what was dominantly reviewed by Health Canada, the regulator, and also, of course, by NACI subsequently. Another thing to consider, as Dr. New was saying, is that we know that intervals do matter, and they do have an influence on the nature of the immune response, the durability, and the level of the immune response. So we've seen a trend with the primary series of the first and second dose, where longer intervals can support higher effectiveness higher immune response and more durability over time. And there are also early indications from some of the literature that a sufficiently long interval between the second dose and the booster dose also results in higher antibody levels. And that it might be the case that actually shorter intervals between second dose and booster dose could have lower antibody levels. So that was certainly all considered by the committee, but I think it's reasonable to say that the largest body of evidence around booster doses is looking at this 6-month interval range. So NACI is always following the evidence and keeping track and looking if there are areas where they can actually try and optimize and deviate from whatever the main body is saying if necessary. But in this case, the largest volume is at 6 months. We're seeing these indications that that longer intervals support higher immune responses. So the committee was most comfortable with 6 or more months for that booster dose. Thank you.
Merci. Opérateur, prochaine question.
Thank you, operator. Next question.
Thank you, merci. The next question is from Abigail Biman from Global News. Please go ahead.
Hi, thanks for taking my question. I noted that there's a question in the report as to whether this third dose is actually a booster shot at all or whether it will eventually be considered part of the primary series. I'm wondering if you can speak more about that and whether we have a better understanding of whether Canadians may be expected to get a shot every 6 months or at some other interval, consistently going forward.
Yes, this is Theresa Tam. I'll begin and I'll look to Dr. Tunis just to supplement the answer. So I think there's a sort of subtlety to that question, and most members of the public don't necessarily understand additional doses for a primary series versus that of a booster. So because we're in the middle of a pandemic, a lot of the clinical trials were done with massive collaboration and as timely as they possibly can. So you don't actually have time to work out all of the different doses, different intervals, and look at what is the best regime for the primary series. So NACI, for example, has looked at the fact that an additional dose should be offered to those, for example, with underlying immune conditions, in terms of immunocompromised conditions, those who don't mount a good immune response, then an additional dose would be important. And that is considered part of the primary series. Whereas the booster dose is to help shore up and elevate that immune response after someone has had adequate, what we call priming of the immune system. And that's what we actually don't really know whether this third dose, for example, for some of these populations we talked about today, is truly a booster or part of what might in fact be a primary series. So it is a little bit complicated. But the bottom line is that if there is waning immunity over time, then an additional dose or boost to your immune system helps, at least in the short term, boost your antibody levels and increase the quality of your overall immune response and the durability of the response. But I think part of it is because we're doing clinical trials and observational studies as the pandemic is progressing. But Dr. Tunis, you have anything else to add?
Yeah, thank you. So I think Dr. Tam has really explained it quite well. And in the committee's analyses and in their advice to us, they've been acknowledging that this is an evolving story. And it sometimes takes years to disentangle the difference between the number of doses required to establish the most strong, well-established primary response versus that recall response or the booster where you're trying to then recall the response or augment it over time. And actually, historically, in other vaccine programs, I think it's worth noting, like for hepatitis or human papillomavirus, that the original authorized schedules did evolve over time, over years. As we learn more and there's, further study continues and we learn how to refine and optimize the schedule and the series, that's a fairly normal progression within vaccine programs. you start with what's available when the products are first authorized and the clinical trials are conducted. And then over time, we iterate, study, and evolve to try and optimize that schedule and that series, and to really use the immune system to the greatest advantage. So I think that it's important that people are aware that we'll continue to see this schedule evolve, and the committee has advised us, on numerous occasions that it's going to continue to be dynamic and evolve over time as we learn more. Also, of course, as we do consider things potentially like variant-based boosters that might be taking the immune system in a different direction over time, the interaction between a primary series and booster doses or booster series is still very much under investigation. So it's, I think it's an evolving story, and it's something that the committee is acutely aware of and keeping track of. But the important thing to remember out of today's advice is that third dose or booster dose is being strongly recommended for a large segment of the population, and then is being also recommended as maybe considered for really everyone 18 and over. So it's probably not important to get too hung up on the definition of the booster versus the primary series at this time, as we know that the situation is evolving.
Thank you. I also wanted to ask, I noticed in the literature released today, if I'm reading it correctly, it says that the risk of myocarditis after the booster is lower than after the second dose, but higher than after the first dose. I'm wondering if you can expand on that, and noting that there are a lot of people still hesitant about a shot for myocarditis, if you could just speak to, how rare it is or not overall.
Yeah, so I'm happy to respond to that. So what we've seen predominantly in terms of myocarditis rates and booster doses has been evidence out of Israel, where the booster program progressed very quickly. And generally, the third dose myocarditis rates have been in the range of around 0.5 per 100,000, which is lower than the rates that we've seen out of second doses, which is more in the range of 2.4 per 100,000. So several fold lower than the second dose myocarditis rate. So it's generally understood that that those myocarditis rates for the third dose is sitting somewhere in between the first and second dose, but it does seem to be substantially lower than the second dose, which is great news. And so the committee's been very encouraged by that, and that's informing their booster advice, and they're very comfortable moving forward with these booster doses because we know the rates are showing to be lower.
Operator, next question, please.
La prochaine question de Louis Blouin.
Next question, Louis Blouin, Radio-Canada, over to you. Good morning. My question is for Dr. New. What would you say to people who are hesitating to take the next dose because they're waiting for the next vaccine, which will be adapted to Omicron? And do you see a scenario where Omicron may become the dominant variant out there? Thank you for the question. I think we already pointed out that here in Canada, the dominant variant is the Delta variant, and it's important to point that out. So Omicron is really not widespread in Canada. It's very new. So it's really important to take it seriously and to study it and to see what its implications might be for the population. But right now, Delta is our variant of concern, and the vaccines we're currently administering are effective against serious illness and effective against Delta. Now, today's recommendations on booster shots are to help improve people's protection against COVID-19. So it is quite possible in future that we might come out with other vaccines more adapted to Omicron or other variants, but that lies in the future. For now, it's really important to point out that it's not a good idea to wait for another vaccine to come out later on. because it'll take several months at least. And for now, it's really important to deal with the situation head on. Next, to your question, will Omicron one day become the dominant variant? Who knows? Maybe this is happening in certain African countries, but it's hard to compare what's happening in Africa to what's happening in Canada. There's so many differences between the two regions, the structure, our demographics, vaccine coverage. We've learned that in South Africa, vaccine coverage is much lower than in Canada. So you have to take all of these things into account. In Europe, in the USA, and here in Canada, it's different everywhere. So we are closely monitoring the evolution of the situation. We will adapt if we need to, but for now, it's really important to state that if you are in a high-risk category, if you are over 50, it's a really good idea to get your booster shot. Thank you. I would like to know what you think of the 12 to 29 age group. You said that it's better for them to get the Pfizer than the Moderna vaccine. In that age group, those who have received Moderna, should they be worried? What are you going to tell the provinces? As far as you know, are there still provinces which use Moderna primarily for 12 to 29-year-olds? What do you tell the provinces? Well, I'm not going to personally speak to the provinces and territories. I work with colleagues. We have colleagues everywhere. We have really good discussions, good conversations on the whole. We take all data into account, and NACI's recommendations are put out there as we are doing today. I believe that those between the ages of 12 and 29, it's very subtle, the recommendation we're making. We are recommending the Pfizer vaccine, which is preferable to the Moderna vaccine. However, both of these vaccines are extremely effective. They are both mRNA vaccines. They both give good protection, and the evidence shows that the real effectiveness of Moderna might even be higher as compared to Pfizer. So in people who are older, in the older groups, this might also be something to be taken into account. So Moderna versus Pfizer. As for young people, if they've had Moderna to begin with, really there is no worry. And as for the side effects, myocarditis, this can appear a week after administration of the first dose, but it's very rare. So but when it comes to the booster shots, as we've already said today, we have to look at the cost-benefit analysis of the Pfizer vaccine versus the Moderna vaccine. However, at the end of the day, the provinces and the territories have their own vaccine campaigns. They all have access to the same information and the same data as we do, and it's up to them to make enlightened decisions with regard to their own vaccine campaigns. Thank you.
Merci. Opérateur, a-t-on d'autres questions au téléphone?
Thank you, operator. Are there further questions?
Nous avons d'autres questions. The next question is from Laura Osman from the Canadian Press. Please go ahead.
Hey there. Thanks for taking our questions today. I wanted to start by asking you about a line in the NACI report that said that issues of global equity were taken into account when deciding on these recommendations. There was not any elaboration on that point. So I'm wondering if Dr. Tunis, Dr. Tam, maybe you could speak a little bit to why it is that we're recommending we give boosters to healthy adults in Canada as opposed to shipping those doses to other countries where vaccine rates are at like 2%.
Well, maybe I'll start, and then Dr. Tunis might want to comment on how NACI deliberated on the equity issue. But NACI does not just take into account science and data, they take into account other considerations as well, which includes ethics and equity. All I can say is that we need to do both. We need to be able to protect our population in Canada using the best available science and the vaccines that we have, as well as supporting other countries. I think we can do that. NACI, as you've seen, have been quite thoughtful. They didn't just rush out and say, everybody get a booster. They've been focusing on the science and focusing on the highest risk groups. So even today's recommendation is has a strong recommendation focus on the 50 plus and those with other higher risk factors. And the younger populations wouldn't have their 6 months probably until the new year for the most part. So I do think that is a balance, and it is a balance of a thoughtful, methodical approach, as well as being able to recognize and take equity into account. Dr. Tunis, I know that NACI absolutely did think about this perspective. Would you want to elaborate?
Yes, yeah, thank you, Dr. Tam. It's been very central in many of their discussions, and they're very cognizant of the the request from World Health Organization to delay booster doses as long as possible, except for those at highest risk. And that's I do agree. I think that's what we're seeing in the advice today from the committee, an emphasis on those where the risk will be greatest and the need is greatest, and then also creating opportunities for others 18 to 49 years of age. And I think it's noteworthy that, as NACI has been continuing to monitor the evidence and to provide us this iterative advice on boosters, the last update being on October 29th, they have tried to acknowledge global vaccine equity as much as possible and really delay the use of boosters until the time when they're really perceived to be needed to get out ahead of potential outbreaks and expansions of disease in Canada. So they've been very central to a lot of the discussions, and I think that is exactly what we see reflected in the advice today.
Thank you so much. I also wanted to ask you, Dr. Tam, about something a little bit off topic on border screening for the Omicron variant. We know that the testing before and after arrival is really thorough. It's catching a lot of the incoming Omicron cases, as opposed to travel bans where, travel bans for select countries tends to be less effective, according to many experts. So what evidence is there to support doing both when testing is going to catch the vast majority of cases?
Thank you for that question. And we will also be discussing, I think, border measures later on in the day with Minister Duclos for one of the press conferences. I think what I would say is that, at the beginning, when things are evolving rapidly, layers of precaution are taken as fast as you can, because really you're trying to buy a bit more time and to delay the spread of the virus as much as you can. As time goes on, once we gain an understanding of where this virus is in the world, then some of those measures will need to be revisited. But I think that those were the fastest measures at the beginning. But we do need to reevaluate them. At the same time, of course, then fine-tuning and escalating some of our testing protocols at the border was done simultaneously as well. And that is also being ramped up in a phased approach according to an analysis of the global risk at this time. So I think both were being implemented as quickly as possible as a precautionary approach at the start. But we will need to re-examine that as we learn more about the virus.
Merci beaucoup. En théorie, on devrait terminer la conférence de presse autour de midi.
Thank you. In theory, this press conference is to end at noon. We have time for a very short question and answer. Operator?
Thank you, merci. The next question is from Cormac McSweeney from City News. Please go ahead.
Hi. I'm just looking for, again, a little bit of clarity on the age group. So provinces can, if they're able to, offer booster shots to people 18 years and up if they choose to, because they're not bound by NACI advice. However, priority should be given to people in the age groups 50 and up, as well as all the other at-risk groups that were mentioned earlier. Correct?
That is correct. And provinces will take into account their population and their demographics and the risk factors. But what you've said is exactly it. I think everyone has been trying to focus on the groups at highest risk. And I hope that the NACI recommendation is very helpful to the provinces and territories. And I think begins to provide some guidance as to which age groups should receive the strongest focus. But it depends on your demographics, depends on your setting in terms of your health services and your ability to access other capacities of the healthcare system. So I think provinces have a tough job in trying to balance all those things. But I think I strongly support the NACI recommendations, and all of my colleagues, the chief medical officers, will also felt that the NACI recommendation was very helpful to them as we discussed them yesterday. So I think we should be able to see provinces roll out their booster campaigns, and please do go and get your booster in that sort of 6-month time interval. It should be in a fairly thoughtful and orderly manner according to their needs.
And just as a follow-up about the 12 to 18 age group and the 5 to 11 age group, so the younger age groups, is it just simply about timelines for when they were authorized to receive the initial series of doses as to why we're not hearing a little bit more about this? Or is there a medical reason that you're not, including boosters for them at this time?
Yes, we're not including boosters at this time because they've only just started their primary series in terms of the 5 to 11-year age group. And one vaccine is now authorized for use. Kids, go get vaccinated, and the parents, please support them. But it's too early, and I think NACI will continue to monitor the evolving vaccine effectiveness over time in that age group.
Yeah, and to add additionally to Dr. Tam's remarks, it's good to keep in mind that boosters for adults were studied in clinical trials also. So there's that dimension as well, that we actually have not seen evidence yet of boosters and for example, the safety profile in adolescents or in children. So that's something that NACI will be carefully watching. And if there is a need or an urgency based on declining effectiveness or something, then there's a possibility that they could provide advice in advance of clinical studies. But we don't see that coming at this time. I think, as Dr. Tam mentioned, it's way too early to be speculating about how that will go in the end. But we know that continued study will be important to inform any decisions about boosters in those groups.
Okay, good job, questioner and doctors. We have time for one last question over the phone.
Thank you. The next question is from Matt Ingram from THCH News. Please go ahead.
Thanks very much for taking my question. I'm wondering if any of the recommendations today, and specifically the 18 to 49 recommendation, was influenced at all by the emergence of the Omicron variant.
Yes, it's Theresa Tam. I'll take that question. So NACI has been making successive recommendations on boosters. They were already scheduled to have the discussions on this next set of recommendations, regardless of Omicron. But again, I thank them for being so diligent and fast that we got a recommendation from them, having the fact that they've reviewed all the data and in such an expedient manner. So it's not because of the Omicron, but I think it's also timely because we're watching the Omicron variant.
Thanks very much. As a follow-up, do you think you could give us an example of someone in the 18 to 49 age group? What kind of situation where it would be appropriate for someone like that to get a booster shot?
Yes, I'll start, and maybe Dr. Tunis will want to add. There's different circumstances, and some people in the younger age group may have received their vaccines earlier. For example, they may be health workers or others, so they may in fact have received the vaccine quite earlier on, and they will be scoped into the group where it is strongly recommended. There are other adults in that age group that may have underlying medical conditions, immunocompromising conditions as well, and those younger adults need to discuss it with their health providers as to whether they should get the boosters now. But for the most part, most of the healthy adults 18 to 29 or 30 to 49, the recommendation is you can certainly go and get your booster, wait 6 months.
Yeah, and to add a little bit more, what what the committee has communicated in their advice is, and you'd see this in the report, that there's a table outlining considerations for jurisdictions and also for individuals about the booster decisions. And so they do outline that the risk of increased waning of protection and or lower protection could be considered by the individual, the risk of severe illness from COVID-19, which could tie into some of those medical principles that Dr. Tam was mentioning, like underlying medical conditions, older age, also racialized and marginalized populations who have been disproportionately affected due to a number of intersecting equity factors. And then the committee also identifies the risk of transmission to individuals at increased risk of severe illness as an individual consideration around booster decisions. So if you're living with or in proximity to people who are at increased risk of severe disease, then that's another consideration. So I don't think there's a single patient or individual profile that can be really outlined, but they've set out these guiding principles that should be considered when factoring in that decision. Thanks.